Alright, let's talk about the physiology of the gallbladder and the bile ducts. It's a relatively simple system, so I'm not going to go into too much detail. Let's keep it simple and clinically relevant. Bile is continuously made by hepatocytes, continuously secreted into the bile ducts, and they continuously are flowing to the sphincter of Oddi. However, the sphincter of Oddi for the most part is closed, and generally only opens in the presence of food and the duodenum. So basically the bile flows up against this closed sphincter of Oddi, and then there's it then builds up and there's backflow after that, and much of this backflow diverts into the gallbladder, which is why the gallbladder is at its maximum size in between meals, just before you eat your next meal. Will be the maximum size of the gallbladder, because the sphincter of Oddi has been closed, there's been lots of backflow, the gallbladder has been filling up. As soon as you eat something, that sphincter of Oddi opens and then the gallbladder flushes out. So if you are working in an emergency unit or in a sonar department and you have to do gallbladder sonars, one of the questions you'll ask the patient, well, when was your last meal? If the patient's just eaten, usually you will struggle to visualize the gallbladder because it's emptied itself out because the sphincter of Oddi opened. Conversely, if you're sending a patient to a sonar, you tell the patient, please don't eat until you've had the sonar, because I want your gallbladder to be full. Anyway, in the gallbladder, water is reabsorbed, which causes the bile to be concentrated. So you've got your liver bile, which is about 97% water, but your gallbladder bile, after some time, becomes 89% water. So there's more solids relative to water, and that's why stones tend to precipitate in the gallbladder, which we'll discuss a bit in a bit more detail on a later slide. Other thing the gallbladder does is acidifies bile. It excretes hydrogen ions into the bile, and thus is one of the ways that the body maintains pH balance in the body. And just to compare, hepatic bile is more alkaline, 7.4 to 8.5 in pH, but gallbladder bile is relatively acidic at 5.4 to 6.9 in pH. Okay, so bile fluid production is stimulated by our vagus nerves, which makes sense because our vagus nerve is a major component of the parasympathetic nervous system. The parasympathetic nervous system controls digestion. You eat, it stimulates the vagus nerve and the parasympathetic nervous system, and we're going to need bile fluids when we eat, so the vagus nerve also stimulates that production. And of course, when you eat, you also secrete a hormone called secretion, which also stimulates the production of bile fluid. And when amino acids and fatty acids enter the duodenum, as a reflex, the duodenum secretes cholecystokinin. Cholecystokinin stimulates contraction of the gallbladder and those bile ducts, and bile floods into the duodenum to help with the digestion and absorption of amino acids and fatty acids. Okay, but now what happens if we have a patient with constant gallstones and even maybe has inflammation of the gallbladder, and that gallbladder needs to be removed to ensure better quality of life? Will the patient die? Well, the answer is no. But there are certain physiological adaptations to your removal of the gallbladder. First of all, instead of having that sort of pulsing discharge of bile whenever you eat, instead of having a sort of those waves of bile discharge, you instead have a constant slow discharge of bile into the duodenum. And also our bile ducts will eventually dilate as an adaptation to the removal of the gallbladder, and that causes almost like a pseudo sort of storage. Because of these dilated bile ducts, it's almost like more bile is present in those ducts, and so that allows a little bit of storage of bile. So the bile ducts become a sort of almost like a pseudo gallbladder by dilating and allowing a bit of storage of that bile. So when that cholecystokinin comes in, these ducts then contract and release the bile that they are storing. So even though we have the slow discharge of bile, we are still able to have a little bit of a wave or increase of bile flow during meals. That said, even with this physiological adaptation, patients may still need to avoid fats with a high fat content, because we need bile to break down fat, and because the body is unable to secrete as much bile as it used to during fatty meals, it might not be able to break down fat, and then you have steatorrhea, fat in your stool, and that can cause indigestion. So patients may want to avoid high fat contents in a specific meal, and may want to break down the fat in their diet to sort of smaller amounts more frequently, so that their bile ducts can easily digest it. Okay, let's go into gallstones and their pathophysiology. Clinical conditions referred to as cholelithiasis. So, if you remember from the liver lecture, bile has several components in it. It has cholesterol and it has bilirubin, and this cholesterol and this bilirubin, as well as calcium, that is involved in the formation of gallstones. And this leads us to classification of gallstones as being primarily made of cholesterol, primarily made of bile pigments, and the pigment part refers primarily to bilirubin, so these are also referred to as bilirubin stones, or mixed. And it's not to say that cholesterol stone is 100% cholesterol and that a pigmented stone is 100% bilirubin. There are various proportions over here that are used for the definition. So cholesterol stone has more than 50% cholesterol. Pigmented stone usually has 20%, less than 20% of its structure is cholesterol, and anything in between will be considered to be a mixed stone. Okay, so where do these stones come from, or how are they formed? Well, we say that the stones form when bile becomes supersaturated. In other words, the relative amount of water in the bile is decreased relative to the amount of cholesterol in the bile, and that allows the cholesterol to precipitate out. For example, if you have a glass of water and you throw in sugar and you just keep throwing in more and more sugar, eventually there's going to be so much sugar in that glass of water that's not going to even dissolve into the water anymore. So what happens? The cholesterol then transforms from micellar type form of cholesterol and it will crystallize out. And there's also something called calcium bilirubinate in the bile. So calcium the calcium is an alternative thing that the bilirubin can conjugate with if the glucuronic acid pathway is overwhelmed. So you got this calcium bilirubinate, and often this forms the core around which the cholesterol deposits. So sometimes you'll even see these gallstones on X-rays because of the high calcium content. But if bilirubin or calcium bilirubinate is the main ingredient of a stone, we rather refer to that as a pigment stone rather than a cholesterol stone. Okay, what also can help with supersaturation of this bile stasis, or inability to empty out the bile. So all that bile just keeps on having, that residual bile just keeps on having more and more water sucked out of it, with more and more stuff being dumped into it by the hepatocytes. That will also contribute to the supersaturation. And if you think about how sometimes you can dissolve things in water just by stirring the water thoroughly, the lack of motion in the bile can also prevent the things from being dissolved into the bile, which would ordinarily have been dissolved if there was enough of movement in the bile. Then we also have these mucins and glycoproteins excreted into the bile. They make the bile thicker and more mucoid, and they prevent water from properly dissolving other constituents, and that can also contribute to supersaturation. If you have bile stasis, you're gonna possibly have infection, and with infection you'll have inflammation. Or if there's the bile stasis in and of itself can irritate the lining of the gallbladder, and then you get inflammation, and that releases prostaglandins, and the prostaglandins stimulate the release of mucin, which just makes the supersaturation problem even more worse. So before we get this situation where we have cholesterol stones precipitating out, before that bile is supersaturated. It's quite often preceded by a sort of pre-supersaturation state that we refer to as biliary sludge. So we've got this gel-like bile filled with mucin, tiny little microstones and calcium bilirubinate, which are just the right ingredients that we need to make ourselves some cholesterol gallstones. Okay, let's talk about other mechanisms that contribute to stone formation. Obviously, if we have a hell of a lot more cholesterol than usual, then we're gonna get more cholesterol stones. And also we need bile salts and phospholipids to make cholesterol micelles. If we have low levels of those, we're gonna end up having cholesterol crystals instead of cholesterol micelles. And it's through this sort of double mechanism of high secretion and low levels of bile salts that we suspect many of the genetic sort of conditions that predispose to cholesterol stones are based on. Some people just genetically secrete more cholesterol and secrete less bile salts. Other thing to mention is that if you have excess cholesterol, it's going to deposit in the sarcolemma of the gallbladder. It's going to mess up your membranes. It's going to impair your nerve conduction. It's going to reduce contractility in the gallbladder, and that's going to cause bile stasis. With bile stasis, you might get infection and then inflammation, or you're going to get irritation of the gallbladder wall and inflammation, with that prostaglandin release, with the mucin release, and then supersaturation and then stones. So it's a vicious sort of circle. Okay, so we've been mostly talking about cholesterol stones. Let's move on to the pigment stones, of which there's sort of two broad categories, the black stones and the brown stones. And our black pigment stones are mostly made from calcium bilirubinate. As I mentioned, it's an alternative conjugation mechanism, and it seems to be the main way that stones are formed in chronic hemolysis. Now, with sickle cell disease or hypersplenism, any disease that has chronic hemolysis can have loss of bilirubin. That bilirubin needs to be gotten rid of. So most of it will go through the glycuronic acid pathway. If that pathway is overwhelmed, then you start using the calcium bilirubinate pathway, and then you excrete lots of this calcium bilirubinate in the background of chronic hemolysis, and that's why people with sickle cell disease or any chronic hemolysis will have a tendency as well to develop gallstones, and there will usually be these pigmented black stones. If there's poor acidification of the bile, that's going to promote these black stones to come out. The acidified bile helps these stones to dissolve. It eats away at them, you could say. So if there's any poor function of the gallbladder for whatever reason, like diabetes or so, and there's poor acidification, you're gonna more likely precipitate black stones. And for some reason that we're not exactly sure about, they're quite rare below the age of 50, and they're usually formed in the gallbladder, and they form against the background of sterile bile, as opposed to brown stones, which are usually in the bile ducts in the presence of infection, which we'll discuss a bit more in the next slide. Okay, so brown stones, as I said, are mostly in the bile ducts, and they mostly are composed of salts of unconjugated bilirubin. So what happens is that we have an infection, and organisms secrete beta-glucuronidase and various other enzymes, and these deconjugate the bilirubin. So you've got unconjugated bilirubin, and then you've got bile salts are also affected by these enzymes, and as the calcium is split from the calcium bilirubinate, the bile acids then make a complex of the calcium, and that makes a calcium salt, and that is our brown stone. And the common sort of culprits for the biliary infections that predispose to these brown stones are E. coli, Bacteroides, Clostridium, all coming in from the GIT. And in Asia, in particular, there's a problem with parasitic infections of the liver, such as Ascaris lumbricoides. And as I said, because of these parasites being more common in Asia, these stones are more common in Asia. The parasites also lay eggs that can have a calcified overcoat, and that calcium in and of itself can form a nidus or core of a stone, in the same way that the calcium bilirubinate can form the core of a cholesterol stone in the gallbladder. Okay, so let's talk about risk factors for gallstones. If you know your alphabet from A to L, you'll be able to tell me the risk factors, because A is for age. So as we age, our gallbladder becomes less effective and there's more stasis, predisposing to gallstones. B is for body shape. If you have a lot of fat in the body, you're going to have a lot of free fatty acids. Hepatocytes are going to convert all the excess free fatty acids into cholesterol, so you're going to have relatively large amounts of cholesterol in your bile. And the same thing happens with rapid weight loss. So if you lose weight too quickly, you have a lot of free fatty acids which are converted into cholesterol and end up causing cholesterol stones. C is for childbearing, and as pregnant ladies, due to the high progesterone, which reduces contractility, various drugs cause gallstones as a side effect. Fibrates prevent reabsorption of bile salts, and then hepatocytes will then absorb cholesterol more aggressively from the bloodstream in order to produce bile salts from the cholesterol, and then some of that cholesterol gets dumped in the bile as well. And then hormones alter your gallbladder function. Octreotide is a drug equivalent of the hormone somatostatin, so it interferes with the hormones that promote gallbladder function and can predispose to gallstones. Ceftriaxone is an antibiotic most often used for the treatment of meningitis, and as a side effect causes stones. E is for ethnicity and F is for family, and basically if you have genetic factors, if you're Native American, Scandinavian, or there's a strong history of gallstones in the family, especially on your mom's side, that is a risk factor for gallstones. G is for genders, because women have progesterone and estrogen, which predisposes them to gallstones. Hyperalimentation, in other words, if you're getting all your nutrients artificially and not from food. Total parental nutrition predisposes to gallstones, possibly due to the free fatty acids present in TPN. I is for intestinal disease, especially ileal. The ileum is where you reabsorb your bile salts, but any intestinal disease can predispose to gallstones by altering the way you absorb your bile salts, which is the same mechanism whereby fibrates can cause gallstones, and of course the various inflammatory cytokines can spread and alter and eventually reach the gallbladder and affect gallbladder's function. And also intestinal disease will alter the function of the sphincter of Oddi, preventing bile from being properly excreted. J is for just about every disease which affects metabolism. So diabetes affects your metabolism. When you're diabetic, you rely on fat breakdown as an energy source. So you have excess free fatty acids. Some of them are turned into cholesterol. With alcoholism, you also rely on breakdown of fat as an energy source, because quite often alcoholics not get enough calories into the system. Any condition where you have high triglycerides, and as you have a lot of free fat in your bloodstream, which is going to break down to free fatty acids, which will make cholesterol. Hyperparathyroidism leads to high levels of calcium in the bloodstream, which then gets dumped into your bile, which can then form calcium stones or form the cause of our cholesterol stones. And low HDL levels. HDL is high density lipoprotein. This lipoprotein scavenges cholesterol and free fatty acids from blood vessel walls. If you don't have enough of the scavenger, all that stuff is just going to float around your bloodstream and can end up in your gallbladder. K is for killed off red blood cells. In other words, if you have hemolysis, you're going to have lots of excess bilirubin in your bloodstream, which is going to go into your gallbladder and make bilirubin stones. Also, if you have weak red blood cells that pop very easily due to B12 or folate deficiency, That's also going to cause excess bilirubin levels. And L is for loss of biliary function. So if you have cirrhosis of the liver, which is affecting the gallbladder, if you have infection of the gallbladder, which prevents the gallbladder from working, and also diabetes can in and of itself damage the nerves around the gallbladder, preventing it from working properly. And that's a fairly comprehensive list of all your risk factors for gallstones. These are my references.